Namaskar, sir.
Progress.
Good afternoon, everyone.
Good afternoon, everyone, sir. Babu, sir, good afternoon.
Good afternoon, everyone. So we'll be starting in 1 or 2 minutes. There's some technical issue facing by the presenting team. So in a minute or two, we'll be starting the training. Sorry for the delay. Good afternoon, everybody. Greetings from NITRD and a heartfelt welcome to all our esteemed guests and colleagues to the third NITRD Paediatric TB Eco Clinic in collaboration with the Regional Paediatric Center of Excellence for Tuberculosis, which aims to disseminate the pediatric TB guidelines and enhance the capacity of healthcare providers in managing pediatric TB at the peripheral level. On behalf of NITRD, I extend my heartfelt warm greetings to our DDG sir, Dr. R.P. Joshi sir, and his team, directors and team from NIIT, NTIs, STOs, directors of STGCs, faculty of medical colleges, district TB officers, medical officers, TB pediatricians, and everyone who is attending to this clinic. Let me introduce the faculty from NITRD. I'm Dr. Saroj Meena, chest specialist at NITRD, and will be moderating today's session. To my right is Dr. Neeta Singla ma'am. She's a nodal officer for conduct of the Eco Clinic at NITRD. And to the extreme right is Dr. Alok Yadav sir, CMO and NFSC. To my left is Dr. Dhulika. She is the specialist pediatric in the Department of Pediatrics NITRD. Now I request our director ma'am, Dr. Manpreet Bhalla ma'am, to give her inaugural address for the clinic. Over to you, ma'am.
Thank you, Dr. Saroj. Good afternoon and welcome all to this. I welcome all the dignitaries for this pediatric TB Eco Clinic. And as was told by Saroj, this is the third Eco Clinic. We started in May 2024 and this is our third session. So I welcome Dr. Rajendra P. Joshi, DDG TB, who is always supporting us. And we also have with us Dr. Varinder Singh, who is the Director, Professor of Pediatrics and Lead of National Center of Excellence for Pediatric TB under NTP. Dr. Ashok Bhardwaj, who is the National Task Force Chairperson, Professor Rajendra Prasad, and others, and from my NITRD. So I welcome everyone for this session. We know that pediatric TB is very challenging and difficult to diagnose as well as for manage TB. And we feel that this session will help us to all the centers and all the sites. It will enable us, like discussing this case, it will help us for diagnosis and management, since we have experts. And experts for today is Dr. Ira Shah, who is the Professor and Head of Pediatric Infectious Diseases at BJ Wadia Hospital for Children. So once again, welcome everyone, and over to you, Dr. Saroj. Thank you.
Thank you, ma'am. Now I request our DDG sir, Dr. R.P. Joshi sir, to give his address.
Thank you, madam. Good afternoon, all. So it is my pleasure to be part of this pediatric echo clinic. NITRD has been instrumental in running very successfully the difficult to treat TB clinic, and this recent initiative of pediatric TB clinic again is another very good initiative. Like Dr. Manpreet Prahlad just told, pediatric TB is something which is not easy to diagnose, not easy to collect a sample, not easy to treat. So it is very important that we get the guidance of the experts in this regard. So on behalf of Central TB Division, I welcome you all. I acknowledge the presence of very seniors like Dr. Varinder Singh sir, Rajendra Prasad sir, Ashok Bhardwaj sir. Then we have got NITRD team led by Saroj Yadav and Singla madam. And we have got Director NITRD and also all the experts, national experts, and the people who are presenting and participating. So on behalf of Central TB Division, I wish all the success and looking forward to learning from you all. Thank you.
Thank you so much, sir. It's always a pleasure to hear from you, and you always take out your precious time from your busy schedules. And thank you so much for this encouraging words, which motivates us to further improve our clinics for the patient care and knowledge dissemination purpose. So now moving on to today's case presentation. This is from BJ Wadia Hospital for Children, Mumbai. And Dr. Reepa Agarwal, who is a clinical associate in pediatric infectious disease, will be presenting the case. Dr. Ira Shah, Professor and HOD, Department of Pediatric Infectious Disease, Nodal Officer of State Pediatric, DRTV Center of Excellence, will be the case expert for today's case. And our national expert for the day, I don't need any introduction for him, is Dr. Varinder Singh. He is Director, Professor and HOD, Department of Pediatrics, Lady Hardinge Medical College, and Associated Kalapati Children Hospital, New Delhi. He is also leading National Center of Excellence for Pediatric TB under NTP. Now I request Dr. Reepa Agarwal to please start with the case presentation. Over to you, Dr. Reepa.
You are taking the screen from sharing the screen. Yeah, good afternoon, everybody. Is my screen visible?
Yes, Dr. Reepa.
Okay, fine. Yeah. So, thank you for this opportunity. Thank you, Ira Madam, for this opportunity, and respected all the seniors in the panel. I would like to now start with the case discussion. So, this is about the 10-year-old girl. First of
Dr. Reepa.
Yes. Am I audible?
Yes, ma'am. Now you're audible.
Okay.
Very faintly audible. You need to get closer.
Okay, sir. Okay. Is it better now?
Yeah, it's better now.
Yes. Okay. Yeah. So I'll restart it. So a 10-year-old girl, first of twin, presented in March 2024 with the symptoms of low-grade fever, weight loss, and loss of appetite for over a month. There was no history of TB contact present. In view of these symptoms, to evaluate the focus of infection, multiple investigations, including a CT chest and abdomen, were performed by the private practitioner. Now this on the right hand side, I'm showing the CT plates. The top one is showing the CT chest, which is showing heterogeneously enhancing necrotic mediastinal, subcarinal, and the upper abdominal lymph nodes were also visible. Now, because of this, there was a radiological suspicion of pulmonary as well as abdominal TB. Hence, the private practitioner started the child on a 4-drug regimen comprising of isoniazid, rifampicin, pyrazinamide, and ethambutol. Now, in April 2024, that is after a month of her diagnosis, she was referred to Wadia Hospital to our OPD. This was because in the 3rd week of her AKT, she developed continuous high-grade fevers, and she was also having some pain in the right hip joint, which was radiating to the right thigh. At that point of time, other infectious causes were ruled out, and now we had a child with disseminated TB without any microbiological evidence with high-grade persistent fever. So this was the clinical problem the child had presented to us. So on examination, the child was vitally stable. There was pallor present. There was no evidence of any peripheral lymphadenopathy, but she had a gibbous deformity in her lumbosacral region, and her abdomen was doughy, and she had hepatomegaly as well. Now here we can see that the child's weight was 22.5 kg, which lies in the 3rd to 10th centile, and the height was between the 25th to 50th centile. The rest of her examination was unremarkable. Now with this, the child was investigated. Here I would like to draw your attention towards the complete blood count. This was in March, and this is in April. Now in March, we can see the anemia was on the similar lines, 9.8 and 9.3, but her ALC, her absolute lymphocyte count, had dropped to 1,031 only. Platelets were 4,13,000, and her inflammatory markers, her ESR had risen from 83 to 107. CRP was now 93.4, and even her uric acid was 9.4. Her LDH was done, which was normal. Triple H was negative, and a blood culture was also sent, which did not do any organisms. Now, with this background, a GL as well as a stool gene expert were done, which were negative for MTB. Just wanted to remind that we did not have any microbiological diagnosis till this point of time. A chest X-ray was repeated, which was normal, and an abdominal ultrasound was done. Now, this time, apart from the hepatomegaly, we also got splenomegaly with tiny cystic lesions, as well as omental caking was present. Now, because the child was also having a gibbous deformity, as well as there was pain in the right hip, MRI of the spine and pelvis were ordered. And this here, we can see that there was involvement of multiple vertebral bodies, C5, C6 over here, and D6, D5, D6 here. Even D8, D9 were involved. And here we can see that there was hyperintensities noted in the hip as well as the femur bone. Now, as I had mentioned in the ultrasound, we had picked up omental caking. For this, we had given a reference to our pediatric surgery colleagues who did a mesenteric lymph node as well as omental biopsy. Now here, if you could see that there is multiple nodular lesions were seen over the omentum during the intraoperative procedure. And now, luckily, with that mesenteric lymph node sample, when an gene expert was sent, we could pick up MTB, and refi resistance was not detected. Similar, a 6-week TB MGIT culture was later also came negative. So now we had a microbiological diagnosis, but we did not know the cause of the persistent fever. So as we had mentioned, there were raised inflammatory markers. CRP, ESR was high. We also sent ferritin which was little bit on the higher side, 227. IL-6 was way high, 25.63. And important to note was that the COVID antibody IgG levels were 637. So now we had a patient with disseminated TB who was also having COVID. And yeah, so with post-COVID and disseminated TB and high serum uric acid levels, the regimen was changed. The PZA was replaced by ofloxacin, INH, rifampicin, and ethambutol were continued. Oral allopurinol was also added. The expert XDR panel was also sent that time. And this showed sensitivity to all the drugs, INH, rifampicin, quinolones, SLI, as well as ethionamide. Now, because of the COVID part, oral prednisolone was started at 1 mkd, and this was tapered over 1 month. So the child received the steroids from 20th April to 20th May. Now, within a week of adding steroids, the fever subsided, and she was discharged a week later. Now, this patient came to us on follow-up, and this time she came with a new complaint. She was having swelling in the right hand on the second metacarpal area since 5 days, and again she was having fever since 5 days. On examination, she had a 2 into 2 centimeter tender, firm, non-erythematous swelling overlying her second metacarpal of the right hand. So a blood workup was sent. In her blood workup, her hemoglobin was 10.9, WBCs were 13,400, neutrophils 81%, lymphos were around 9.7% with an ALC of 1,300, and platelets were 4 lakhs. TSR is now 84. We also did an immune deficiency workup, which came out to be normal. And for that metacarpal swelling, we had taken a reference from the orthopedic surgeons. They did an incision and a curettage, and they had sent the pus for gene expert, which also showed MTP and REFA resistance was not detected. At present, the 3 weeks MGIT is no growth and 6 weeks is awaited. Even an MRI of the hand was done, which showed that there was involvement of the shaft of the third metacarpal with cortical breach along the soft tissues, and there was also edema in the subcutaneous plane. Reactive edema in the interosseous muscles was also found. Now, this is the recent clinical picture a week back. Now she is much better. She's having weight gain of almost 2.5 kgs in 4 months. There is no pain in the hand. However, she has some difficulty in making a fist on the right side. And on the management part, she has been started on steroids at 0.5 mkdo. Her AKT comprising of INH, rifampicin, ethambutol, and ofloxacin has been continued. Now, we plan to repeat her MRI right hand and her MRI spine with pelvis after a month. So, this is the...
Thank you so much. Thank you so much, Dr. Reepa. It was an excellent case presentation. Just to summarize the case, this is a case of a drug-sensitive PTB in a 10-year-old girl who was started on first-line ATT on the basis of clinical radiological diagnosis in the month of March 2024. But after 3 weeks of start of ATT, she presented to the Varia Hospital for complaint of high-grade fever and pain at several sites like hip joint, which was radiating to thigh, and she had severe pain, for which she was investigated in detail. And because the patient was previously diagnosed on the basis of clinical radiological basis, so detailed workup was done at Varia Hospital, which include the MRI imaging of the pelvis and the spine, and which showed multiple involvement of the vertebral bodies, left scapula and pelvic bone, and including the right femoral shaft also. Ultrasound abdomen was also done, and CT abdomen was also done, which was suggestive of abdomen cause. Thereafter, patient was underwent biopsy from the omental biopsy, and the mesenteric lymph node biopsy was done, and that showed granulomas in the histopathological examination. And gene expert from the biopsy samples showed MTB detected and the resistance was not detected. The sample was also subjected to measured culture, which came out to be negative, and to the expert XDR panel also, which was also suggestive of the drug sensitive PTD. During the investigation, it was noted that her uric acid levels were also elevated. So the team decided to replace pyrazinamide with ofloxacin in this case. And symptomatically, patient was treated with oral allopurinol along with oral prednisolone. And with this treatment, patient responded to the treatment and her symptoms subsided. After 2 months, in the month of May, she again came up with a metacarpal swelling. For which she was being diagnosed with acute osteomyelitis, and incision, debridement, and curettage of the metacarpal was done. And the patient was managed with this, continued with the same treatment of INS, rifampicin, ethambutol, and ofloxacin, and with the plan to follow up in the future. So the house is open for questions on the based on history. Dr. Ira, you can stop sharing your screen now.
So I think there are some questions in the chat box.
Yes, we can take those questions. Ma'am, like you have emphasized a lot on the ESR. So the first question was on the ESR in the chat box.
Ma'am, you're not audible. You have to come near to the.
So we are not emphasizing on the ESR from the point of view of TB, but
ma'am, still you're not audible. Please come near to the device.
Okay, can you hear me now?
Yes.
Okay. So we are not emphasizing on the ESR as a part of diagnosis of TB. What was here important was you have a child who has drug-sensitive TB. She's been started on the treatment in March. She continues to have fever till April, and the ESR is rising. Okay. One thing that you have to keep in mind, which I think a lot of us in India don't really look for, is TB and COVID go hand in hand. And if you look at this child, the COVID antibody titers were positive. Now, if somebody will tell me, they will say that COVID antibody can be positive, it has got no meaning. I will tell you an example. Whenever we see a child who's running fever with TB, in spite of being on the sensitive drugs, you always look for signs of POTS. POTS is postural orthostatic tachycardia syndrome. So if you find that the sleeping heart rate and the standing heart rate in a patient is varying, so suppose you have a sleeping heart rate of say 90 and suddenly your standing heart rate goes to 120, then you know there is a postural orthostatic tachycardia syndrome, which is very classical of COVID. Another marker for COVID is lymphopenia. So if you see the March investigation, the child had normal lymphocyte count to begin with, which went low. You could get lymphopenia also with TB. So that's not a marker specific for COVID. But on treatment, the lymphopenia should improve and it should not go down. So that is another marker that tells you there is something else happening in this child. So two markers, one is postural orthostatic tachycardia syndrome and a lymphopenia. And you see the inflammation is going up, the ESR is rising. So that is what made us suspect COVID in this child, and we did a COVID antibody. Now, COVID antibody in this child was 600 something. A titer, usually COVID antibodies disappear within 2 years after you get COVID. When you get COVID, initially your titers will be somewhere 2000 plus. 4 to 5 months down the lane, your titers will be around 600 to 800. So this fits classically into a post-COVID syndrome. And that was the reason why this child was given steroids as part of post-COVID syndrome. So it's not a typical miss. It's not a typical PIMS, but it's a post-COVID, long COVID that you see with TB. So this is the first thing that we wanted to emphasize on this case, that whenever you have persistent fever, you think of a lot of things. You think whether this child has got a treatment failure, whether the drug doses are properly administered or not, whether the child is adherent to the treatment, whether this is drug-resistant TB. If all this has been ruled out, then you think of other causes of fever that is persisting.
Okay, so that was the first point that we wanted to make over here. It's not a routine run-of-the-mill case for TB, but it's something that you will see in your clinical practice very often. The other thing is, on treatment for drug-sensitive TB, the child comes with a TB dactylitis after 2 months of therapy. So the question is, why did the child develop dactylitis? Can anybody in the audience tell me this? Can anybody tell me why the child developed dactylitis after 2 months of being on drug specific, I mean, the specific ATT to which the child is having sensitivity?
Yeah. See, actually, it might be due to paragenamide because it causes at times gout-related problems. So it might be not in a toe. It might be had happened in this metacarpals. It's my opinion.
But pyrazinamide will cause gouty arthritis. It causes gout because the uric acid goes up. It won't cause a dactylitis where your pus is drawn and from that pus you have picked up TB. If you remember the child, we had done a curettage of that metacarpal, and that also picked up MTB on the gene expert. So this is not pyrazinamide induced. Pyrazinamide induced, this child only had a high uric acid, and for that we just replaced the pyrazinamide to ofloxacin. Somebody mentioned iris in the chat box. So what do you mean by iris over here? So in HIV, we call it as iris, where there's an immune reconstitution on treatment. In TB, we call this as paradoxical reaction. So paradoxically, where the child is actually getting a culture which is negative, that means you are killing the bacilli, but you have a clinical or a radiological worsening. That is known as a paradoxical reaction, and it is because of the immune reconstitution that occurs. Normally, paradoxical reactions, you will see a pleural effusion coming, or you will see a tuberculoma coming up, or you will see lymph nodes enlarging or new abscesses forming. You will usually not see an osteomyelitic abscess coming as a paradoxical reaction. Here, why I'm saying paradoxical reaction, because if you look at the omental biopsy that was done in April, we had a gene expert which was REPA sensitive, but we had an MGIT culture at 6 weeks which was negative. So that tells me probably the gene expert picked up a dead bacilli and the culture is not growing any bacillus. So that's why it's most likely an immune reconstitution, which you call it as a paradoxical reaction. So this is another aspect. So don't restrict yourself to a thought process that paradoxical reaction means only pleural effusion, tuberculoma, or lymph nodes. These are the common paradoxical reactions, but you could get a clinical or a radiological worsening with a culture that is negative on treatment. So treatment of paradoxical reactions, usually you don't need to treat this. You just continue the ATT as it is. You may need to treat it if it's causing a problem. Say, for example, if it's causing a lymph node that is draining into an abscess, it's increasing in size, or a pleural effusion that is causing respiratory distress, then you may need to give steroids. So not all paradoxical reactions require steroids. It is to be based on a clinical judgment whether this is needing treatment or not. Somebody has mentioned that steroids itself can worsen the dactylitis. Yes, the bone involvement can worsen, but nobody knows the dose of steroids that you need to give in paradoxical reaction, whether you need to give 1 milligram per kg, 2 milligram per kg. The ideal dose of steroids that you give is just enough.
पीछे चलेगा इससे पीछे चलेगा
Hello. Yeah, so the ideal dose of steroids that you give is just enough to control the paradoxical reaction. So if you see in this patient, we have just started with 0.5 milligram per kg of steroids. It's not going to be a standard regimen that you give 2 months, 3 months, or you give 1 month and taper. You will have to follow up this child on a regular basis, and you will have to individualize the steroid therapy. You may come down in a week's time. You may come down in 2 weeks' time, depending on how the response is.
Thank you so much, ma'am.
Nita may come for some time because I have to leave.
Yes, sir. Yes, sir, please.
I think first at the outset, I'll say I'm not pediatrician, but we treat lot of tuberculosis, including pediatric. I mean, case was very well presented and very well treated, I must say. But one or 2 points I want to, probably I have not seen X-ray of this patient. When you have such a big lymph nodes, probably X-ray might have some finding which might have been missed. So that was the one issue. Second, pyrazinamide, well, serum uric acid was very highly raised, but we have seen in adults, at least I have no experience of children. We have seen in adults in such situation, pyrazinamide is ultimately retolerated because what I believe that in this drug-sensitive TB treatment, pyrazinamide is a very important drug. Because if you don't give pyrazinamide, then it will not be a shorter duration treatment. It will become literally a duration of a longer event. So
Yeah, you're
pyrazinamide
absolutely correct.
might have been tried
No,
again.
you are absolutely correct here. What we did is we gave allopurinol to the child. We've
Right.
repeated the uric acid, which is normal. Now we have stopped the allopurinol. We are again going to repeat the uric acid. If it is normal without allopurinol, we'll be restarting the pyrazinamide and stopping the ofloxacin.
Yes, yes. Okay, madam. And the third point I would like to raise, I think the role of steroid in such cases is definitely there. Two, three aspects, I must say, in this case. It was a disseminated tuberculosis. In
Yes.
disseminated tuberculosis, even in our books, we have written that steroids may be indicated and it may require for some time to control the serious sickness, high fever. And second was there was a lot of caseating lymph nodes in the what I saw in the CT scan. So in caseating lymph nodes also sometimes what I have experienced in adults that sometimes addition of lymph node makes a lot of difference. And the third point why steroid can be used in this case because of the some doubt of iris because some iris might have been taken place of lesions were going from one place to another. So I think case was to me case was very well managed, but these are the few smaller points I would like to raise. Nita, I'm sorry, I have to take another class, so I'll be leaving. Thank you.
Thank you so much for joining, sir. Thank you so much.
Thank you.
So before we move to the question and answer, let's take opinions of our national expert, Dr. Virendra sir. Sir, would you like to comment on the case?
Yeah, thank you very much. Thank you, Ira, for a very nicely worked up case and a challenging case to share. I would like to deconstruct it in a little different way. For the audience, it is very important to understand if you deal with such a situation, what are the thought processes which would have gone into the mind of the treating team? So if I see a child whom I have got a diagnosis which is not microbiologically proven, but is a clinical radiological sign, and he comes with a non-response, what are the questions which should be entertained at that time? First question is it TB at all? Because a clinical radiological TB always has a lot of differentials. So the team worked out, went even to the extent of an invasive diagnosis to confirm that it was MTB. So that's a very important point because a lymphoma can mimic similar situations. So a non-response, we as TB clinicians are only tuned to think in terms of drug resistance. While what it should start with is it, first of all, is it TB at all? The second question which becomes very important is, okay, it is TB. The commonest form of TB is drug sensitive. Was it drug given in right combination, right dose, taken by the child, not vomited, adherence, because a non-response could also be because drugs were given but not taken, or were not given in the right combination or right dose. So that's the second important issue which we look at. Area where Dr. Ira Shah works, Mumbai is a hotspot for drug resistance. So the obvious next question comes to you is that, okay, am I dealing with drug resistance? Is it a failure of therapy? So there again, the team worked out, got a microbiological diagnosis where it shows risk sensitive. The advantage of a second line expert, as I prefer to call it, rather than XDR, because it's no more
that XDR, it only tells you the SLIs and fluoroquinolones in addition to ethanamide and INH, is that you are able to get, if you are not getting a response with rifampicin containing regimen when it is RIF sensitive, the other thing you are worried about is INH resistance. So XDR panel is able to tell you whether there is INH resistance or no INH resistance. That's the advantage you get with an XDR panel, which otherwise, if this was not a extra pulmonary case and you had sputum, you could have done with an LPA, because that would have given you an RHA. So that's another thing which is very important. I'm trying to dissect it out for the audience, how one has to think in terms of the diagnostic processes to be followed, because these are rapid ways of knowing what you have, but they will never tell you whether it is a dead or an active bacilli, for which an MJIT is required, and that is why an MJIT was sent, and that if that had come positive would have added to information that it was still a disease which has not improved as much. A culture tells us that possibly, which Dr. Ira's team is trying to say, is that it was a kind of a paradoxical increase. It was a disseminated disease which had spread all over. Still, before we go there to the paradoxical, one important thing is to do a therapeutic drug monitoring. And it may have been done. If I have missed it, I do not know. But that's another thing you would like to look at, that, okay, drugs were given in the right dose, but were they absorbed? Some patients are rapid acetylators. They may not have adequate blood levels. So despite having a drug sensitive disease, they, particularly in extrapulmonary, the response may not be adequate. So that's something which helps us whether we need to increase the doses or continue. That's something you need to look at the TDMs going further. Now, a bit about why there were dissemination. So amongst the things which also come to your mind for dissemination is sometimes when we see the diseases is what is most clinically apparent disease. But the dissemination is by hematogenous route also, and often you have involvement of other areas which may be clinically silent when you start, and gradually those lesions, you can have a paradoxical increase. You can, just as a lymph node can enlarge despite having a drug sensitive disease on therapy, any lesion can enlarge. But if this enlargement occurs in an area which was not clinically evident earlier, then the difficulty is it a new lesion, or is it a lesion which has now become clinically evident? And that's where you want the basic differentiation you want is drug sensitive versus drug resistant. So that was sorted out. The persistent fever is something which would have been worrying for the team, because usually in a paradoxical reaction, forget iris where you have a lot of systemic reaction. Usually in a paradoxical reaction, you do not have so much of fever or constitutional symptoms in an immune competent host. So that is why possibly they looked at other causes. One of the things which is relatively less well understood or documented is the para-infectious complications. So is the para-infectious complication of tuberculosis, which does happen and which can give rise to pyrexia. Collection of pus, undrained pus which has not been taken out, is also something which can give rise to increased ESR because of continuous inflammation, and can also give rise to fever, despite being an adequate therapy, because this pus is striking out, trying to come out, and that keeps the inflammation alive. Even the dead bacilli keeps it alive. I am aware that COVID is involved in several ways. On that, I would take a little softer view, simply because a lot of we did not identify an acute illness. IgG can be present. We do not know how long it has been present. One, whether she had a COVID 6 months back or 2 years back, we have no clue on that. So yes, it could be because there is lymphopenia, but lymphopenia of that degree is possible in a single slide, without in a single test, without having an acute infection at that time, is little difficult. But long COVID, you can have some degree of lymphopenia. So that's something which is kind of one could argue either way, but it's not material to this case further management. So important thing here is that the paradoxical reaction is time and increasing. What I would like to know from Dr. Ira's team, again, I don't know whether I missed it, whether they looked at the interferon gamma receptor, pathway, STAT1 or receptor, because they're not easy to do. If we have anything on those deficiencies, because they are the one where, despite with the having a good amount of antibiotic and a sensitive bacilli, antitubercular drug, because the intracellular killing is poor, the disease may continue to proliferate for a longer time despite adequate therapy. So that's something one really needs to keep in mind, that whether it is a MDSM or whether it is something which is related to a interferon gamma receptor SA pathway defects or a STAT1 defect, which could have this kind of presentation. So that's all from my side.
Thank
On
you, Dr.
OFLOX, there are a lot of questions on OFLOX, whether it should have, but I think Dr. Ira has said that it was just a temporary measure. Usually, we do not need to take off, pyrazinamide, or don't even need to replace it. But here was a situation: the child was still continuing to run fever. So the concern of the team that, okay, they may not have adequate coverage, and replacing it with OFLOX could have been the reason for doing what was done. But and they also had an XDR report which said that it was fluoroquinone sensitive. So it was a reasonable, I would say, step, but not something we would otherwise routinely recommend, as even Dr. Ira is saying, because we do not want to use fluoroquinolone as an add-on drug to category 1. That's not what this team is suggesting at all. So that's all from my end. Over to you, Ira.
Thank you, Dr. Varinder. That was a very excellent, comprehensive overview that you gave and an approach to how to go about in this patient. The thought process that you highlighted was exactly the way that we thought about this patient. And I think the way you explained it has made things very clear to the audience. So thank you very much. What you mentioned about MSMD, mycobacterial susceptibility to mycobacterial diseases, Mendelian susceptibility, we have sent the test, the report is awaited. We have done NBT, that is for CGD, that is your chronic granulomatous disease. We have done a lymphocyte subset analysis, immunoglobulins, all that is normal. The MSMD workup is still about to come. So that is one thing that is still pending. But thank you for highlighting that. That was wonderful.
Yeah, but it was expected from your team to have done it fully, but it's good. But it's important for the audience to know how you think and how it goes.
Yes.
Thank you so much, sir, for explaining each and every point in so much of detail. STDC West Bengal, they have raised their hand. Sir, do you have any comment to say? Sir, you're muted. Please unmute yourself.
Ma'am, am I audible?
Yes. Yes, sir.
Actually, just I heard that the case of dactylitis, ma'am said that it is due to, perhaps maybe due to iris. Now, my question is that we have heard this during HIV cases. So, as there is no case of immunosuppression, but my question is whether the administration of steroid causes immunosuppression, so that is that gradual withdrawal of steroid or proper regimen raises the immune status. That's why the iris develop, and that's why the dactylitis caused.
Yeah, so your question whether steroids can cause iris, no, steroids will not cause iris. The iris is caused by the immune system because that is getting reconstituted. So if you look at the CD4, CD8 cells, they are coming up and that is what is causing the iris. And in fact, to treat the iris, if it's causing a lot of problems, then you give steroids to suppress the immune system. So the steroids are not going to lead to iris. So if you feel a worsening is happening and it's because of steroids, then it's actually not a paradoxical reaction. It's because the immune suppression is going on for a long time. So you have to really look at it clinically. What was the cause of when this child developed dactylitis, the child was already off steroids. So it's not.
What is the cause of immunosuppression in this case?
So we may consider that one is, as we said, we are looking at MSMD, whether there is a congenital immunodeficiency in this child, because this child has a very disseminated disease. You have mediastinal nodes, you have omental, so you have abdominal TB, you have bone involvement, including the femur bone, the spinal, multiple areas. So it's a very unusual presentation of TB. So probably there's some congenital immunodeficiency that could be there in this child, and we are awaiting the results of that.
Okay, ma'am. Thank you.
The other thing I would like to add here is that in all cases of paradoxical increase, you do not always get an immune deficiency. So people have hypothesized that this may be just a local event, that locally, because of the overwhelming infection, it was not being able to control, and it goes, and once the bacilli are killed, the local reaction by the lymphocyte is so aggressive that leads to a increase in sizes. So that has been postulated. There is no way to prove it.
Yes, exactly.
Thank you, sir. Dr. Rishi,
Yeah. Ma'am, as you have mentioned that since a patient was on pyrazinamide and patient had developed this, so you stopped the pyrazinamide and you had started giving Uflox. And my concern was that Uflox can also cause arthropathic children. And we usually don't recommend for giving Uflox, fluoroquinolones in children because it may in future also give rise to this XDR. So my concern was what was the extent of giving this Uflox to how much duration? Is it possible we can give fluoroquinolones also in such a case, madam?
Yeah,
As
so
would be easier.
the arthropathy with fluoroquinolones is something which has been proven in animal model. It's still not been proven in human beings. And we have also used it in neonates, though it's contraindicated in neonates. We do use quinolones in neonates. We've not seen long-term arthropathy with quinolones in children. Here, as I said, the consideration was only as a temporary till we could go back onto pyrazinamide in this patient. So it's just while pyrazinamide was omitted for the hyperuricemia that it was replaced by ofloxacin. As soon as we are able to start back the pyrazinamide, we will be stopping the ofloxacin.
My concern was it necessary to give Uflox without stopping pyrazinamide? Was it necessary? That's why my concern also, ma'am. Why was the need of giving Uflox, ma'am?
The uric acid was extremely high. It was 9.9.
Okay.
And we have seen children who develop gout with uric acid. So at that moment in time, to continue pyrazinamide becomes a little problematic.
Oh, yeah, I know. Yeah. Okay.
What possibly Dr. Rishi wants to say is that why not give pyrazinamide and continue with the rest? As I said, the reason they chose to replace rather than abandon pyrazinamide was because child was still running fever, was active, was concerned that the disease may not be fully controlled. And they had an XTR panel report to say that it was fluoroquinolone sensitive. So possibly those were the reasons for them to select an alternative drug to pyrazinamide rather than leave it totally to 3 drugs, which would have been, because it was still in the initial phase of treatment, was still in the intensive phase. We were still close to about 6 to 8 weeks of therapy at that point of time.
Okay,
is that right, Dr.?
Yeah. Got it. Thank you.
Virendra sir, like this is a case of a disseminated cough, which is also involving the bone and the spine. So how long are we should give the treatment in such case, duration of treatment and.
So the current agreement is at least 12 months of therapy. There are trials which have said 9 months, but they have not been fully adapted. So current recommendation by the index guideline from the country on extrapulmonary TB or WHO guidelines still says when it is spine and bone TB, then it is 12 months. In fact, the trouble is that our friends in orthopedics often like to give it for 18 to 24 months. So before we go to below 12, we first have to bring everyone from 18 to 12. Having said that, what is also important to remember is that these are the cases which sometimes have deep-seated abscesses, and they are difficult to reach, or they are sometimes intramedullary, and there because of a persistent phlegmon. If on an individual case basis somebody wants to extend, then I would request my friends in the TB sector, please do not be very dogmatic. You may allow on an individual basis, but most of the patients would be fine in 12 months and not less than 12 months. And on a case-to-case basis, if they give you enough evidence, you may extend.
Thank you, sir. Thank you so much, sir.
If you want, we do have a few slides on paradoxical reaction if you want us to share it with the audience.
Sure, ma'am. We can go ahead with it.
Okay.
Ma'am, before that, I just want to make a small announcement. We have already shared the pre-test link in your respective email. Now we have also shared the post-test link in the registered email ID. Please attempt that. That will help us to further improve us and we'll get a sort of feedback form. Now you can go ahead, ma'am, please.
Thank you. So this is just an overview of paradoxical reaction. So paradoxical reaction is a form of TB iris, as we have discussed, that may occur during or after completion of the anti-TB therapy. But what is important is that we have to rule out drug resistance, adherence issues, secondary infection, malignancy, and even rheumatological disorders before we label it as paradoxical reaction. With neurological deterioration, they can have pleural effusion, ascites, and in CNS TB, they can even have tuberculomas. There could also be progression of the lymphadenitis. Now, when can it occur? So there is no specific timeline. Paradoxical reaction can occur from 1 week to even several months after initiation of anti-TB treatments. And it is most frequently seen in patients with extrapulmonary or disseminated TB, as was in our patient. Now, the incidence of paradoxical reaction in HIV negative patients is to the tune of 2.4 to 23%. But the morbidity of paradoxical reaction is 11 to 36% in individuals who are co-infected with HIV who have been recently started on highly active AR. Now, what is the mechanism? So this is based on hypothesis. So what is important to note is the host as well as the interaction between the host and the bacilli. So if the host has an immune deficiency or has a low baseline lymphocyte count, then of course, then iris is this paradoxical reaction can be because of that. That is when we start treating, the immunity comes back. That is the CD4, there is renewal of the CD4 counts. Or from the beginning only, as Dr. Varinder sir was mentioning, it could be because of some local reason. So whenever in the beginning only, if there is a high baseline number of bacilli, so when there is rapid killing of these bacilli, because of that also it can lead to a paradoxical reaction as the microbial products are released. And ultimately, it is the recovery from the TB-induced immunosuppression which occurs when the patient has been given appropriate and adequate AKT. So how do we manage? This has been discussed in details. There is no consensus. So for medical management, it could be just the AKT, or we can also use corticosteroids. Surgically, we can use interventions like drainage, aspiration. In our case, there was drainage as well as curettage done. And there is some evidence of vitamin D, which is recognized as an immunomodulator in TB infection, and it may mediate paradoxical reaction in anti-TB treatments. So this was just an overview about paradoxical reaction. Thank you.
So there's Dr. Vrinder, there's a question to you. We have many doctors who are here and who are working in periphery. So what would be the take-home message for them when such a pediatric patient comes to them? What are the things that they should keep in mind?
So I think when it is disseminated TB and involving extrapulmonary, it is something which has to have involvement of more than one specialty. It is not just TB alone, because there are a lot of things which an orthopedician may do. You may need a surgical help for diagnosis. You may need surgical help for sometimes a complication of TB. Should there be an obstruction to gut because of the gut blockage, or there is need for a decompression of spine or a joint. These are the issues which will be best dealt by the surgeon. A role of pediatrician would be to look at whether there is a background immune deficiency or anything else which is causing it. So the most important message for them to know is that if it is a drug failure case, then this has to go through the whole paradigm of testing, as I mentioned a little while ago, confirming that it is diagnosed, diagnosis is correct, doses, drug, adherence, drug levels, and then the complications and the drug resistance. So it is not one singular diagnosis which should be kept in mind or only thought of. Often it is that, okay, we did a CB0, it was RIF sensitive. So what? It is the child is not improving. You have to find the cause. And RIF sensitive could be resistant to other drugs. RIF sensitive could be that there is a low levels, or it could be that the disease is the symptoms are because of a concurrent other illness. We have seen patients also having concurrent other illnesses which are the cause for fever. So that is why a more detailed investigations or linking up with the pediatric team would be required in the least, and also for the specific extrapulmonary involvement for the concerned specialty.
Right. Thank you, sir. In different clinics that we've been doing, in last few months, it has come up that there is a need of doing TDM in most of the cases. And since CTD is also here, we need to develop more and more facilities which can do the TDM, which would help the clinicians to manage their cases better. So that's one message, at least we should try to pursue that every state develops a TDM lab for themselves.
So TDM is something which also has a lot of quality issues. So the samples, how fast they reach the lab, particularly for INH. So a standardized methodology of identifying the drug levels is something which is required. And this is also something where our knowledge is still evolving. So if you look at the earlier studies, we were very happy with the MIC which we got with 5 milligram INH and 10 milligram arsine, and then we changed and we changed and we changed. So this is something which we're still learning, and it is going to have some learning curves. To begin with, yes, there is a definite need for developing more data on this, for which you need standardized labs. And TDM should not become just a level or a number where we start chasing that number. Okay, this is less, therefore this is the cause. This is more complex than just a simple number. But I totally agree with you that we are at a stage where we do need more facilities for TDM. Thank you.
Thank you, sir. I think with this we end this today's clinic, and I request Dr. Ashok Bhartwaj, sir, who is the chairperson, National Task Force, to give his closing remark for the session. Sir, over to you.
Thank you, Nita. Thank you for giving me a chance. So it was a wonderful case for which I congratulate the team from Wadia Hospital, the case presented by Dr. Ira Shah, and the expert comments by the expert from that hospital. So as Dr. Vrinder Singh also told, we must follow the adopted EPTB guidelines. In 2016, they were index TB guidelines, and the newer guidelines prepared by AIMS New Delhi were, the TOT was held in first week of November last year. So we must follow these guidelines, and we must disseminate these guidelines to each one who requires it. So Nita, I am very happy that the participant touched 230 today. So hopefully, because it's the only third in the series, so hopefully the number of participants will increase to more than 500. So I disseminated your message to each one in the country. So hopefully in future also they will attend. So thank you very much. Wonderful case and wonderful comments by Dr. Vrinder Singh. It's always nice to hear. Thank you.
Thank you, sir. Yes, it was
One last thing, can I add, Dr. Meena?
Yes, sir, please.
Yeah, there are standard treatment walkways made by ICMR on pediatric pulmonary as well as extrapulmonary TB. I would strongly urge the people who are attending to go on ICMR website and download them. They're one-pagers, and they are quite useful in many situations, which tell you a kind of a decision algorithm, what to do for a given type of presentation of TB in children. So standard treatment walkways, if you will type STW for TB, you will get on ICMR websites. They have been created for adult as well as pediatric extrapulmonary and also pediatric pulmonary.
Thank you, sir. That will be helpful to each one of us. Thank you for the information. And with this, we end today's clinic. I again request you to, there's a post-test link has been shared in your registered email ID. Please attempt that. And the next pediatric eco clinic will be held on 20th of August 2024. And it will be from Dr. Varinder Singh's team. Kalavati Saran Hospital will be the case presenters. And with this, thank you so much for attending today's session and for your feedbacks. Thank you.
Thank you. And congratulations, Dr. Ira, for a beautiful case. Thank you, everyone.
You are right.